Hi, Miss Nikki here. Welcome to chapter 28. We're going to review the male structures. I start with this image because I think it's really interesting. Here's an egg or an oocyte, and all of these are sperm that are attacking this egg and trying to get through this outer covering. And we'll talk about this a little bit more when we move into development. The primary reproductive organ for the male is testis, or testes. This is plural. Testis is singular or one. And then we're going to look at some of the ducts, the tubules, the accessory glands that contribute to the formation of semen, and then we'll talk about the copulatory organ, the penis. The testes are going to lie inside the scrotum. So this is a skin-covered sac. It provides a cooler environment. That's the function. Sperm development and maturation require lower than body temperature, so lower than 98.6, and remember that's an average. This is homologous to the labia majora of the female. The majora are the outer lips of the female, the ones that are covered in hair surrounding the entrance to the vagina. There is also a midline. There's a raphe. This marks a location between the two embryonic tissues. So you're going to have the scrotum, and there's this line between. They are separate compartments. So if something happens to one of the testes, it doesn't spread over into the other. A scrotal wall here, external layer of skin. There is a fascia, a superficial fascia internal to the skin, and then we're going to have the location of several muscles that are going to help to provide temperature homeostasis for the testes that are inside the scrotum. So we have this structure called the spermatic cord, and this is a little hard for people sometimes because we have to remember that the testes or testis start in the pelvic cavity. So the testes are like the ovaries, and then eventually the testes are going to descend through the inguinal canal, right? So this is going to pass through the abdominal cavity, through this inguinal canal into, so the testes drop into the scrotum. So this spermatic cord is a multi-layered structure. It has blood vessels, testicular arteries and veins. You're also going to see nerves. You're also going to see the ductus deferens inside this spermatic cord. It has several layers. There's fascia, there's muscle layers, right? So there's an internal fascia, an external fascia, and then this cremaster muscle. So far we've seen two muscles, dartos and cremaster. So here we have mention again of the testicular artery. They want you to realize that we have an offshoot of the abdominal aorta. Before we were calling them gonadal arteries and veins. Once they're going through the inguinal canal and they're going to the testes, they're usually called testicular arteries and veins. So with elevated temperatures, why do we have muscles inside the scrotum, and what do we need to do to maintain that temperature homeostasis so that the sperm can develop? So with elevated temperatures, the dartos muscle is going to relax and the testes are going to move away from the body. So if the body temperature starts rising, the testes are going to move down further away from the abdominal cavity. The cremaster muscle relaxes and allows the testes to move as well. So both of these, if you have elevated temperature, you're going to relax the muscles and you're going to allow the testes to move inferiorly. If you're cold, so decreased temperatures, if it's cold, the dartos and the cremaster are going to contract, and that's going to pull the testes closer to the body. So this helps conserve heat. Here's the male pelvic region. We can see the testis here. We can see the epididymis. We'll talk about this in a second. We can see the ductus deferens. And you can see this ductus deferens goes through this inguinal canal. There's another picture coming up. So now we're going over the top of superior and inferior of the bladder. And then we're going to see a widening of the ductus deferens. We call that the ampulla of the ductus deferens. Then we're going to see the seminal vesicle, which is going to contribute fluid. And then we're going to see these contents travel through what we call the ejaculatory duct through the prostate here, and then through the different sections of the urethra out the external urethral orifice. So we'll go through this several more times, but this is the pathway that sperm take from creation, right? So this is the creation of sperm. And they have to travel through this tube system. We have ducts, we have glands that are all going to contribute, and then the ejaculate that we'll talk about is semen. It's made up of fluid from all of these glands, and then it also has sperm from the testis. Here's another image, kind of doing a little better job of showing the spermatic cord, right? So here's the spermatic cord coming through the inguinal canal. They're showing you the cremaster muscle here. We also have on this side, you can see they've pulled away those fascia, the internal and external fascia layers that make up the spermatic cord, and now you can see some of the interior contents. So you can see that there's a ductus deferens, you can see the testicular nerve, testicular artery, you can see the epididymis here, and then you can see the testis itself. And this is more kind of what we see in lab. We kind of see these, not a cadaver image, but more of a model image, and you can see the spermatic cord here, the wrapping, all the contents, the muscle, cremaster muscle layer, and then when we take those away, remove those, you can actually see the interior contents of the spermatic cord and the scrotum. So testes or testis, these are small organs, right? They produce sperm and androgens. There is a parietal and a visceral layer, so they're covered by serous membranes. These are derived from the abdominal peritoneum. Remember, the peritoneum are the internal layers of serous membrane, right? The visceral is closest to the organ, and parietal is closest to the wall. And so it makes sense if the testes have to descend into the scrotum, and that these start in the pelvic cavity, that they're going to have a visceral and parietal layer of the peritoneum with them as they move through that inguinal canal. So the actual tubules that are making the sperm are called seminiferous tubules. And we'll see an image in just a second. They're very convoluted. It's hard to trace all the way through these seminiferous tubules. There's about 4 per lobule. There are some non-dividing cells. So there's these sustentacular cells. These are going to help kind of nourish the sperm, bring nutrients to the sperm. They're going to release a hormone called inhibin when sperm count is really high, and inhibin can act as a negative feedback and go back and tell FSH secretion to stop, right? We're doing what you told us to do. We're creating sperm. And on the next image that we have, we'll walk through this whole process. So there are germ cells in the seminiferous tubule that are continuously dividing to produce sperm. So what's the site of sperm creation, right? So sperm is being created in the seminiferous tubules, and the seminiferous tubules are inside testis or testes. So here's a nice image. You can see what we meant by convoluted. It would be hard to trace this tube system exactly back. And we do have names for all of these different layers in tube system where they merge, right? So we have the lobules. They're showing you the visceral and parietal outer serous membrane layer coating. And then all of these seminiferous tubule lobules are going to join together. We have straight tubules, efferent ductules. We're not going to concentrate on those. If you can tell me these are seminiferous tubules and this is the site of sperm production, this is just the passageway. How do they get to the epididymis, which we'll talk about in just a second. So testis, seminiferous tubules, they're going to merge and form the epididymis, and then the epididymis tube eventually becomes the ductus deferens. There is a blood-testis barrier, so developing sperm have to be protected, right? from the body's leukocytes. So think about this for a second. Sperm development, when does it happen? Are boys as old as 1 producing sperm? No, right? So this happens at puberty. Have you already educated your T cells? Remember, we talked about the process where antigen presenting cells bring cells to your thymus and you kind of check off, okay, these are Ms. cells, you're supposed to be here, everything's good, right? So if we didn't have this blood testis barrier, your immune system would attack sperm because they weren't there when you were educating all of your T cells, right? So they would be seen as foreign. So we have these tight junctions between sustenacular cells that form this blood testis barrier. So the whole point of this is to stop your immune system from attacking sperm cells, right? There are some spaces surrounding the seminiferous tubules. Those are interstitial spaces, and we have some interstitial cells. So we'll look at a microscope slide in just a second, and these interstitial cells are the ones that are stimulated to produce androgens by the luteinizing hormone. The most common androgen is testosterone, and we're going to see these interstitial cells that are releasing the majority of testosterone once the male has gone through puberty. They want to just make sure that you remember we still have hormones, small amounts of hormones secreted from our adrenal cortex. So remember those gonatocorticoids, right? So when we learned about estrogen, progesterone, and testosterone back in endocrine chapter, we were talking about adrenal cortex. So remember, after puberty, it's the actual sex organs that are producing the majority of those hormones like testosterone, estrogen, progesterone. So here's a nice cross-section image of a seminiferous tubule. You can see the outside here in this lighter pink, that is the seminiferous tubule. So all of this would be seminiferous tubule. On the outside here, you can see we have interstitial cells. Here, we're going to have germline cells. These are called spermatogonia. These are the cells that are going to be triggered to create sperm. And we're going to see these cells divide, go through meiosis, and then here we're actually going to see sperm. So what are all these? Those are all sperm tails in the lumen. So they're spermatids, and then we'll see that process, spermiogenesis, in just a second. So we're going to start talking about the hormones. So since I have this picture up, I just want to make sure we realize that the follicle stimulating hormone is going to actually talk to the sustenacular cells inside this seminiferous tubule. But basically, the bottom line is the FSH is going to stimulate sperm production. Over here, the interstitial cells, we have LH, and LH is going to cause those interstitial cells to release androgens. We're just going to say testosterone. And we're going to see how both of these have to be functioning in order to drive sperm production. We're going to start with the hypothalamus, right? We're going to go through the words and then I'll show you the image. The hypothalamus secretes GnRH. GnRH stimulates the anterior pituitary to secrete FSH and LH. So FSH is going to stimulate spermatogenesis, LH is going to stimulate androgen production, but you need both of them really to have sperm development. So LH is going to stimulate the interstitial cells to secrete testosterone. FSH is going to stimulate the sustenacular cells to secrete something called androgen binding protein. This is going to bind to testosterone and keep the levels of testosterone high within the testes. So it's both of these, the androgen binding protein with the testosterone attached to it, bound to it, and that is going to help keep testosterone high, and that is what's going to help with sperm production. So this increased testosterone stimulates or facilitates spermatogenesis. It also acts as an inhibition. I've already been told to make sperm. I'm going to make sperm. So it can go back and inhibit GnRH. So it's that negative feedback effect. And then sustenacular cells, if this testosterone remains high, sustenacular cells release something called inhibin. And inhibin basically can inhibit the FSH secretion from the anterior pituitary. So again, this is another additional feedback mechanism. You've told us to make sperm. We are making sperm because the testosterone is high, and the androgen binding protein bound to the testosterone is making it high in the testes. So we're going back and saying, okay, you can shut off FSH and LH. Testosterone also stimulates the libido and the development of secondary sexual characteristics. So remember axillary, pubic hair, deepening of the voice, facial hair. So here we have the image. You can see gonadotropin releasing hormone from the hypothalamus is causing the anterior pituitary to release FSH and LH. LH is going to go to the interstitial cells, and the interstitial cells are going to release testosterone. FSH is going to stimulate the sustanacular cells to release androgen binding protein, which is going to bind with the testosterone to keep the levels of testosterone high in the testes. The combination of the testosterone and the androgen binding protein, having this high level of testosterone, is what triggers spermatogenesis. So then we're going to see the germ cells there divide, and create the sperm in the seminiferous tubule. In the red, they're trying to show you the feedback mechanism. So remember, I guess think of this as on, right? So FSH and LH are released, they go to the testes and they say, turn on, create sperm. So once the testes are creating sperm, we don't need to keep sending the hormone message, right? I mean, you don't want somebody telling you nonstop, make sperm, make sperm, make sperm. So when there's enough testosterone, when the testosterone is high enough, when the seminiferous tubules are undergoing spermatogenesis, you're going to see the sustanacular cells release something called inhibin, and inhibin can come back and turn off FSH and LH. Also, if testosterone level is high enough, it can also act as a secondary negative feedback, and it can turn off GnRH. So the reason that I talk about this is when we get to the female, it's a little bit more complicated. It's not just an on and an off. It's an on, off. We kind of vary, and that'll make more sense when we get into the female. But there's no reason to be secreting GnRH, FSH, and LH if the seminiferous tubules are already in the process of making sperm. So some of the terms, a lot of sperm terms here, so kind of want to get these straight. Spermatogenesis is the overall process. So process of sperm development, think of it as the umbrella term, right? So spermatogenesis is what's happening in the seminiferous tubule. It begins during puberty as soon as your FSH and LH levels are high enough. Spermatogonia are those primordial germ cells. Those are the germ cells from which all sperm are going to develop. They are diploid. You do have 2 of every chromosome. They're near the base of the seminiferous tubules. We'll talk a little bit more about this process in the next couple of slides, but they're going to divide by mitosis, and then eventually this primary spermatocyte is going to do meiosis. We're going to see primary spermatocytes, secondary spermatocytes, and spermatids. Then we're going to see this term spermiogenesis. This is really the final stage of spermatogenesis. This is when spermatids, which are circular at first, are going to become mature sperm. So we're going to see mature sperm, right? This is kind of the immature. If we see mature sperm, we're going to see several features. We're going to see the flagella. We're going to see a midsection that has tons of mitochondria. We're going to see the head section that has DNA, and then there's going to be this enzyme, this acrosome cap that has digestive enzymes to help the sperm penetrate the oocyte. So that was that first microscope image that I showed you with the oocyte with all the sperm on it. So basically the sperm brings with it DNA to deposit into the oocyte, but it also brings the enzymes to help it get through the outer covering of the oocyte or egg. That mid piece is going to have tons of mitochondria. So this right here is going to have lots of mitochondria. Hopefully you're already making the ATP connection. If you have lots of mitochondria, then you're probably doing lots of ATP. And does it make sense that to move the tail so that sperm can get through the female reproductive tract, you would need lots and lots of ATP, right? So here's the image of spermatogenesis and spermiogenesis. So they're showing you here the spermiogenesis. This is the starting cell here, and this cell has to become fully mature till we get to the acrosome cap, the DNA, the midpiece with all the mitochondria, and the flagellum. But let's go back and start up here. I'm going to switch colors. So up here we have the spermatogonia. So this spermatogonia, or gonium for one, is going to divide and do mitosis. So remember, mitosis, identical copy, right? You have 46 chromosomes. You're going to have two cells that have 46 each, and they are identical copies. So if you notice, this cell right here, this primary spermatocyte, is the one that's going to divide and trigger meiosis 1 and 2. This cell is going to kind of be in reserve, right? So that you can do this process again. And I think this is nice to show in purple the sustenacular cells, right? So these sustenacular cells kind of provide the nutrients in the background for all of these cells to divide. So we start with a spermatogonia. It's going to copy itself with mitosis, and then one of the primary spermatocytes is going to be triggered to undergo meiosis 1 and meiosis 2 so that we can end up with haploid germ cells or haploid gametes. So in this process, we're going to see the primary spermatocyte is going to undergo meiosis 1. This is where we would have the crossing over, right? The exchange of genetic information. Then we're going to end up with 2 secondary spermatocytes, and then we're going to have meiosis 2, and we're going to end up with 4 daughter cells, all having half the number of chromosomes as the original cell. So we've got our 4 haploid daughter cells, or gametes. So then we have to do spermiogenesis because they start as these circular cells, lots of cytoplasm, and we kind of have to modify to get to this fully functioning sperm. So male versus female, they just want to point out that even though females, we haven't really talked about them yet, but females do meiosis 1 and meiosis 2, but there's only going to be a single viable egg or oocyte. And we'll talk more about that when we get to female. But males, there's going to be 4 sperm produced. So for females, that we're going to see 1 oocyte from every oogonia, and in males we're going to see 4 sperm from every spermatogonia. So female oocyte is arrested in meiosis prior to birth. Females are only able to reproduce until menopause. Males don't start spermatogenesis until puberty because it's triggered by that increased level of testosterone, right? And male spermatocytes are produced throughout a male's lifetime. So those primary, secondary spermatocytes just continue production. Females, menopause is anywhere between 45 and 55. So a couple of differences here from the way that gametes are developed in males versus females. Males over the age of 45, 4 times more likely to pass on genetic mutation than men in their 20s. Maternal age is not correlated with the increased risk in these particular disorders. Both of the sexes carry a risk of developmental problems the longer their sex cells age. So now we'll go through the duct system. So we're starting at the seminiferous tubule, and we showed in a previous image that from the seminiferous tubule, the sperm go to the epididymis. So the epididymis is this kind of arced structure. They call it a comma-shaped structure. There's a head, there's a body, there's a tail, there's a duct of the epididymis, and basically its function is it stores sperm until they are fully mature and motile. So that means movable, right? Motile. There's the ductus deferens. Sperm enter after leaving the epididymis. It's within the spermatochord. It extends through the inguinal canal into the pelvic cavity around the bladder, where it's going to meet at the prostate gland. And you're going to see this ampulla of the ductus deferens and the seminal vesicle, both of these merge and form the ejaculatory duct that's in the prostate gland. So nice image here. We see the seminiferous tubules. We see them emptying into the epididymis. We see the epididymis becoming the ductus deferens. It would go through the inguinal canal around the bladder. And now you see the widening. So you see the ampulla of the ductus deferens. You see the seminal vesicle that we'll talk about, the gland. They come to this point, which is called the ejaculatory duct. And then they're dumped into the urethra. And this bulbous structure right here is the prostate. The ejaculatory duct is this small duct that conducts the sperm or moves the sperm and the seminal fluid towards the urethra. So it opens into the prostatic urethra. So you're going to see that ductus deferens come around. That ductus deferens is going to widen. That's the ampulla. And then you're going to see the seminal vesicle here, and they're both going to dump into the ejaculatory duct. And then the ejaculatory duct is going to dump into what would be prostatic urethra. The urethra has 3 different components. It has the prostatic, the membranous, and the spongy urethra. So here's the ejaculatory duct. Here is the prostatic urethra. Here is the membranous urethra. And then we have the spongy urethra. So again, anytime we have a long tube system, we're usually going to name different sections of the tube so that we can identify issues more clearly, right? So now we get to talk about these accessory glands and the production of semen. So the seminal fluid, this is an alkaline secretion. Hopefully remember our pH greater than 7, right? Alkaline. And this is to neutralize the acidity of the vagina. So we'll talk a little bit later, but the vagina is acidic. Remember, the vagina is exposed to the external environment. Do we want bacteria or fungus to be able to set up shop in the vaginal canal? No. So the inside of the vagina is acidic, so that means it would be below pH 7. So the seminal fluid, the sperm are in the seminal fluid when they're ejaculated. In the semen, there is these alkaline secretions from the seminal vesicle to help kind of negate the acidic vagina environment. We're also going to look at some of these other glands. All 3 of these contribute to semen. All right, so we're going to see in semen, we're going to have sperm, and we're going to have secretions from all 3 of these glands. So the seminal vesicles, just giving you a little information. Where is it? It merges with the ductus deferens, forms the ejaculatory duct, secretes an alkaline fluid, and this is important. Fructose. What is in the seminal vesicle secretion? A sugar. Does it make sense that there's mitochondria in the midpiece of the sperm, and now we're going to have the sperm swimming in fructose? So is it possible that sperm could take that fructose and use it to convert to glucose and make ATP to fuel the movement of the flagellum? Yeah. So prostaglandins are going to help promote the widening of the cervix. So we don't know this really yet, but here is the uterus. And then we have the cervix. And then we have the vagina. So the sperm are traveling in the vagina. They have to get through the cervix. Then they have to get into the uterus. Then they have to get out to the uterine tube to actually get to the oocyte. So this is pretty important, right? What are the sperm bringing with them, right? So we've got the tail, right? So this is for movement. We've got here mitochondria, right? Powerhouse of cell, energy factory, right? Then sperm have DNA, and then they have that outer acrosome enzyme, digestive enzyme. Now we know they bring their own sugar to produce ATP to power the tail movement, right? They also bring prostaglandins with them because they want to be able to get through the cervix so that they can get into the uterus, to get into the uterine tube, to get out to the egg. And then once they get to the egg, do they have digestive enzymes to chew through the outer coating of the egg? They do. So pretty amazing that they bring all of this with them on their journey. The prostate is also going to contribute. So the prostate gland is going to produce mucus. It's going to secrete this fluid that has citric acid in it, and citric acid kind of maintains sperm health. Citric acid can act as protective chemical for DNA. Then there's something called seminal plasmin. Seminal plasmin is an antibiotic that combats urinary tract infections. And then it also makes something called prostate-specific antigen, which liquefies the semen following ejaculation. So the prostate is also contributing. It's contributing to sperm health. It's making sure there's no urinary tract infections in the male. It is also secreting this antigen. And think of it as when sperm is ejaculated, it wants to be able to stick at first, right? It has to get through the cervix. It has to get into the uterus. It has to make its way all the way out the uterine tube to actually get to the egg. But when the sperm starts swimming, we want them to be in a more liquid-like environment. So kind of think of it, at first, it's going to stick and coagulate a little bit, and then this PSA is going to allow the semen, remember semen is the fluid and the sperm, it's going to allow the environment to kind of liquefy so the sperm can continue moving through this fluid out to the egg. And then the bulbourethral glands. So these are paired glands. They're going to be right next to the external urinary sphincters. They're also going to be in that membranous urethra area, right? So I'll show you on another image. But the bulbourethral gland enter the spongy urethra. They produce a clear, viscous mucus. And really what this is going to do is lubricate the urethra. And it's going to, I think the way this is worded is a little misleading. It's going to lubricate the glans penis, and it's going to coat the urethral lining, right, that spongy urethra, and it's going to clear any urine or anything that's not supposed to be in the urethra, anything that could damage the sperm as the sperm are traveling through the urethra. So what is semen? It is seminal fluid and sperm. But remember, this seminal fluid comes from 3 sources, right? So it's not only the seminal vesicles, not only the bulbourethral gland, because that comes out first and clears out the urethra, but it's still part of semen. And then we have our prostate, right? So that fluid that's coming from the prostate. And then the sperm, which are coming from the seminiferous tubule. So we call this ejaculate. There are about 200 to 500 million sperm. That is quite a bit, right? So we'll talk about how only a few of those actually make it to the egg to help breach that outer covering of the oocyte. The rest are going to be lost or damaged or attacked by the female immune system. So can we have issues in this entire process, right? Common in older men, you'll see the prostate will enlarge. So this could be due to hormonal changes. It could be nodules within the prostate. Something to think about is the prostate is homologous to the female structure of the uterus. And I'm sure we've heard of women that have had like fibroids in their uterine walls. So it is common for nodules to form in the prostate as well. And this will cause frequent urination at night. It could be painful. Sometimes it could be treated with drugs. Sometimes you can have surgical removal of wherever that enlargement area is. Prostate cancer is common in men over 50. It's one of the most common malignancies. And you can see there's hard, solid nodules within the prostate. They're cancerous cells. They can start spreading. Usually it is screened with a digital rectal exam. So they're talking about inserting a digit into the rectum and feeling for an enlarged prostate or a tumor on the prostate. They can also do the PSA test. So if you think about it, if you have a prostate and it's enlarged and it's a proliferative tumor, we talked about these when we talked about the thyroid, right? So if it's a proliferative tumor, then it's pushing out tons of hormone or tons of protein. And in this case, the PSA test would be really high. We're going to move on to the copulatory organ, which is the penis. This is part of the external genitalia along with the scrotum of a male. There are different sections of the penis. There's the root, there's a body, there's a glands, that's the tip of the penis. This is where we find the external urethral orifice. This is the exit, right, for ejaculate. And then in some cases, prepuce or foreskin. In most cases in the United States, men are circumcised where this foreskin or prepuce is removed. We really need to focus on these paired, well, there's 3 cylindrical erectile bodies. There's a paired corpora cavernosa, and then there's 1 corpus spongiosum. So corpus spongiosum is around the spongy urethra. It is continuous with the glands of the penis. We're going to see the corpora cavernosa. These are 2, and then there's 1, and then the urethra would be inside the spongy. So here they're showing you where the crus of the penis is, where the bulb of the penis is located, the actual body of the penis, and the glans penis. And then here we can see the external urethral orifice. So this is what they mean by external genitalia, right? The things that are outside of the body. Now we're looking at a cross section of the penis, so you can see the structures. Here's a corpus cavernosum, so singular. Plural would be corpora cavernosa, but there is only 1 corpus spongiosum, and here's the spongy urethra. You can see that there are arteries inside the corpus cavernosum, and then you can see the venous drainage on the dorsal side. So, phases of male sexual response. There's the excitement phase. So what's going to happen? The erectile bodies of the penis have spaces, right, surrounding the artery. So we just saw that picture, central artery and lots of space around it. Blood fills in the spaces during excitement. So blood's going to fill in the spaces and cause the erectile body to become rigid. And so we call this erection. Compresses the vein drainage. So blood is going into the tissue, but it is not able to get out. So blood unable to leave the erectile bodies until excitement is over, right? Until climax. This is caused by the parasympathetic innervation. So local release of nitric oxide is responsible for the increased blood flow into the venous spaces and for the penis erection. Near the end of this phase, heart rate, blood pressure, respiratory rate all increase. And sometimes people have issues with this because it throws us off. We think parasympathetic is rest and digest, right? Some people like to think of this as point. So you'll see in just a second I guess if you wanted to think which one requires more effort, parasympathetic, it's just the erection of the penis, where you'll see in the next phase in the next slide that for ejaculation to occur, you have to have all of these muscles contract, and so that is controlled by sympathetic innervation. So if you think of erection as point, and it's controlled by the parasympathetic division. So orgasm, intense pleasure, tension release, and this is kind of the key, right? Expulsion of semen. So the ductus deferens is going to move the sperm towards the urethra. Remember, there's a ductus deferens, and it goes to the ampulla of the ductus deferens. then along with the seminal vesicle dumps into the ejaculatory duct, then travels through the prostatic urethra, membranous urethra, spongy urethra, right? So that's kind of what they're talking about. The accessory glands are going to all contribute their fluid components. So when we say accessory glands, hopefully we're thinking about seminal vesicle, prostate, forgot my S in there, but and then bulbourethral gland contents will be there as well. You're going to have internal urethral sphincters contracted. So there's internal at the base of the bladder, and if these contract, it stops the flow of urine from entering the urethra. We do not want urine in the urethra while semen is in the urethra. It will kill the sperm, right? That's the whole point of having the bulbourethral gland clean out the urethra, right? All right, ejaculation at the end of orgasm. The semen is expelled from the penis with contractions in the muscle of the urethra and occurs because of sympathetic innervation. So a lot of people think of ejaculation as sympathetic innervation because you're shooting out the ejaculate. So that's point and shoot, right? So after ejaculation, we call this the resolution phase. Intense relaxation. The sympathetic division stimulated the contraction of the central artery of the penis. Remember, we're contracting all of the muscles to cause ejaculation. This also contracts the central artery of the penis. It stimulates the small muscles around the erectile tissue that help expel the engorged blood. So now the penis is soft and flaccid again, and there is a refractory period. So at some point, there's no erection possible, and this could be minutes to hours, and this becomes longer as you age. So there are some issues that can arise with men. Decreased testosterone levels in their 50s, usually decreased number of interstitial cells, and remember those are the ones that are triggered by LH to release androgens, which get converted into testosterone. Usually the decline isn't that great. It's not as significant as women when they go through menopause. Men have very few symptoms. They can have mood swings, decreased sex drive. Remember, testosterone is what we think is the basis of sex drive. They can have hot flashes as well, but it doesn't seem to bother men as much as it does women. The prostate can enlarge. This does just kind of happen with age. Those nodules start developing. This could interfere with sexual function, expelling of sperm and seminal fluid, urinary functions, right? So if the prostate nodules are pressing on the inside of the prostatic urethra, you're going to have a hard time letting urine exit into the urethra. And then we can also have erectile dysfunction. So basically the inability to achieve or maintain an erection. This happens with aging. Other risk factors like high blood pressure. So high blood pressure can cause, can interrupt with the blood flow into the erectile tissues. So think about if you had blockage of blood vessels, if you had hardening of arteries, you wouldn't be able to pump as much blood into the erectile tissues. So some issues that can occur. So that concludes the male structures and information for chapter 28. So next video, I'll cover the female, and then eventually in chapter 29, we'll start talking about development. Talk to you soon. Bye.